So I'm going to hand over now to Elizabeth Beach, who's our colleague working within NHS England and Improvement, and she will talk about the improvement and assurance schemes within NHS England and NHS Improvement. You're on mute, Elizabeth, so you might need to start again, please.
I'm going to start again. Hello, my name's Elizabeth Beach. I'm the Regional Antimicrobial Stewardship Lead in NHS England and NHS Improvement in the South West region. I have co-authored the chapter on the improvement and assurance schemes that occurred in 2020-21. Next slide, please. And you can see that the overview of these show that there was I'll be covering the focus on the policy involving a reduction in antibiotic consumption by NHS trust providers of acute care, sequence schemes, the Right Care UTI products, which published in that year timeframe, the continued focus to reduce antibiotic prescribing in primary care, which obviously you've heard about already from Sabine in terms of what that reduction looks like. And for the first time, the community pharmacy contract has antimicrobial stewardship in it within the pharmacy quality scheme. Next slide, please. So in terms of reducing antibiotic consumption by NHS trust providers of acute care, there had been a plan within the contract for 2020-21 to extend the reduction of 1% from the previous year to a 2% reduction. So this would be a 2% reduction total antibiotic consumption against the same 2018 calendar year baseline. However, the standard contract was stood down because of the pandemic, and this requirement therefore did not apply in 2020-21. And as you're probably very aware, this 2% reduction requirement is in this current 2021-2022 contract year. So that is in place at the moment. Next slide, please. And it's a similar stand down story for the NHS England and NHS Improvement Sequence Scheme. So there had been a plan to implement an AMR sequin for all acute UTI for all adults in acute trusts. And this scheme had been prepped and brought to readiness, but all sequence schemes were stood down in 2021 and have continued to be stepped down in this financial year. So there's no sequin activity to report at all last year or this year. Next slide, please. However, I'm pleased that that something did happen in 2021, and the Right Care UTI products that had been in preparation before the pandemic, they did have a delayed publication, but it did provide an opportunity to revise and refresh that data, and these did publish in 2021. Right Care UTI was part of the exit strategy from a 2017-19 quality premium scheme, which aimed to improve empirical management of or empirical use of nitrofurantoin in primary care for the treatment of lower UTI, while also reducing trimethoprim in older people, with the ambition of trying to reduce risk of E. coli bacteremias. And as an exit strategy from that 2-year quality premium, the Right Care UTI data packs were developed and produced. So these include a variety of data around hospital admission rates for UTI, E. coli bacteremia rates, as well as new primary care antibiotic prescribing metrics, which are focused on the use of antibiotics to treat lower UTI in adults aged 70 plus. These prescribing metrics are also reported in a new NHS BHA EPAC2 dashboard, which is the first time we've had a Right Care aligned EPAC2 dashboard. So great collaboration there by those organisations. And this reports the new metrics. They're reported as rolling 12 months, and they're updated every month. The focus is very much on improving the management of lower UTI in older people. One of these new metrics is a person, not an antibiotic prescription metric, and it reports the number of people who have trimethoprim prescribed more than once in any 3 consecutive month period. And this is aligned to the NICE antimicrobial prescribing guidance for the treatment of lower UTI, which recommends that if you have trimethoprim, have had trimethoprim in the previous 3 months, then you might not want to use that as empirical antibiotic first choice. And the current ongoing work with the NHS Right Care UTI data is the development of system level data, which pulls together all of these different data metrics in one place on the NHS model health system. And this allows data such as the fingertips community urine drug bug data to be pulled into that as well. So it provides you with a really nice oversight at a system level of what urinary tract infection activity looks like at a system level. That is currently in development. Next slide, please. We mentioned there'd been a continued focus to reduce antibiotic prescribing in primary care. The NHS oversight framework was in place in 2020-21, and you can see here the two very familiar primary care AMR metrics, antibacterial items per star PU and proportion of broad spectrum antibiotics, have continued to be reported in the oversight framework all the way through the pandemic year, through 2020-21, and we've seen huge disruption to the use of these metrics because, as Sabine has already reported, there's been a very large reduction in antibiotic prescribing in primary care, particularly antibiotics associated with respiratory tract infections. So this has impacted CCG performance against these two metrics. As you can see here, in the last financial year, 2020-21, nearly all CCGs met or exceeded the national target to be at or below 0.965 antibacterial items per star PU, compared to the previous year, when only about half of CCGs met or exceeded that target. This has also impacted the calculation of the broad spectrum metric. There's been a very big reduction in the denominator value because of that big reduction in total antibiotic item count. And therefore, we can see that in 2020-21, about 44% of CCGs met or exceeded the target of at or below 10%, whereas previously that had been running at about 90%. So a large impact of the pandemic on these two metrics. It is worth noting that the actual number of items of broad spectrum antibiotic prescriptions has continued to reduce throughout 2020-21. So this is a spurious increase in metric value because of the way the metric is calculated. So advice to use these metrics with caution, and that continues to be the case. Next slide, please. Both metrics have been retained in the new NHS System Oversight Framework, which was introduced in this financial year. Two differences. CCGs continue to be included in this oversight framework, but systems have been included. So we now report at STP level as well as CCG level. And the national target for antibacterial items per star PU has been reduced from 0.965 to 0.871. But again, just to iterate, continued disruption to the use of these metrics because of the impact of the pandemic on antibiotic prescribing in primary care. As usual, performance continues to be reported in the usual place, and the link is referenced in the report. Next slide, please. So finally, for the first time, we have an antimicrobial stewardship requirement in the Community Pharmacy National Contract in the Pharmacy Quality Scheme. And this has been, this is multifaceted. It involves patient-facing pharmacy staff that provide advice on medicines or healthcare to have completed the PHE antimicrobial stewardship for community pharmacy e-learning and e-assessment module. In addition, contractors, so pharmacy contractors, must have developed an antimicrobial stewardship action plan for the pharmacy, which details how they will promote AMS. And thirdly, all patient-facing staff that provide health advice should also become antibiotic guardians and be aware of their local antibiotic formularies, both for primary and secondary care. There is continued content in this year's pharmacy quality scheme, and this includes the requirement to utilise the antibiotic checklist, which has been covered previously by Diane. Thank you.
Next slide. Thank you, Elizabeth. Virtual claps for you there. We're now going to move on to professional education, training and public engagement, and I'm going to invite Catherine Hayes to share with us.
Hi, good afternoon, everyone. So yeah, my name is Catherine Hayes. I'm a researcher in the UK Health Security Agency Primary Care Interventions Unit. I'm presenting this chapter on behalf of Jana Leckie, who is the chapter lead, and it covers professional education and training initiatives and community engagement in England during the 2020 to 21 year. So we're all aware that the COVID pandemic had an immense impact on the healthcare profession, and unsurprisingly, there was a drop in interest in education and training. And research shows that there was an initial overprescribing of antibiotics in primary care. However, there was a renewed demand for training following the first wave of the pandemic, particularly around refresher training, antibiotic prescribing guidance, and remote consultations. Next slide, please. So across sectors, there was a switch to remote learning during the pandemic. In general practice, the target antibiotics toolkit included a couple of remote training resources. So there was a 6-week prescribing in primary care FutureLearn course. There were 2 remote prescribing webinars, one focused on decision points for remote management of common infections, and another focused on using national antibiotic resources to help improve antibiotic prescribing. And additionally, 2 target train-the-trainer remote workshops were held. So this was to train healthcare professionals to be champions in AMS. So in the community pharmacy setting, as Diane and Elizabeth mentioned, there was the e-learning session on the role of community pharmacy staff in AMS was part of the pharmacy quality scheme. And then the ESPAUR group held a webinar to support this in March, and it featured a panel of pharmacists who discussed implementing the target antibiotic checklist. Additionally, the Royal Pharmaceutical Society continued their AMS programme, and this was training pharmacists to lead AMS initiatives in their workplace. So in dentistry, a 3-week online course was developed by BSAC and the World Dental Federation, and again on FutureLearn. So this was designed for an international audience, and it aimed to provide a tailored action plan to help dental teams tackle antibiotic resistance. Next slide, please. So for secondary care, a webinar was held in March, and this covered the impact of COVID on prescribing and also shared learning on hospital AMS initiatives carried out during COVID-19. For the education sector, there were 2 eBug e-learning courses developed. The eBug Health Educator Training course was co-developed with BSAC, and this was hosted on FutureLearn. It provided training to educators to help kind of train them in using eBug activities and delivering IPC and AMR education to schools and communities. And another e-learning was developed for the early years setting, and this was developed to support preschool staff, particularly around implementing COVID-19 guidelines, and it was very highly received and attended. Also, the 4th National Student AMR Conference was held last November as a completely virtual event, and it included lectures and workshops covering a One Health approach to tackling AMR. Next slide, please. So what does this mean in terms of engagement? So despite the unprecedented times, over 132,000 participants engaged in learning on AMS to support the public, which is really phenomenal. A large number was community pharmacy staff, which really highlights the impact of the pharmacy quality scheme. But it is important to note that this just gives us a flavour of what's going on because we can't capture the local initiatives. Next slide, please, is on to public engagement. So eBug, as mentioned, is an educational resource for the school and community settings. It covers education around infection prevention and AMR. So eBug has been a really key resource for schools during the pandemic, and the team has reacted to COVID through developing a few new resources. So the educator e-learning has had 4,000 enrolled, and the one for preschools has had 4,500 enrolled, which is excellent. Also, new posters were developed for schools, which had 16,000 downloads. eBug worked with the group NABU to develop a storybook called My Back to School Bubble. The aim of this was to help alleviate children's anxieties about returning to school during the pandemic, and it was downloaded over 12,000 times that year. So all this combined meant the e-bug was highlighted in the Department of Education's coronavirus guidance around teaching about hand and respiratory hygiene. And as mentioned, it's had a record-breaking 2.8 million views in the last year, which is amazing. Next slide, please. So on to professional engagement. So the Antibiotic Guardian campaign uses an online pledge-based approach based on behavioural science to engage human and animal health professionals, scientists, educators, and the public. So by the end of 2020, there were over 112,000 pledges, and 36,000 of these alone were made during 2020, which is double any other annual figure. And despite the pandemic, 106 organisations registered AMS activities during 2020. Next slide, please. So we've talked about public and professional engagement, and now to highlight a project that brings these two areas together really nicely. So the Antibiotic Guardian School Ambassadors Programme aims to connect healthcare professionals with local schools. So traditionally, healthcare professionals would visit their local school and deliver fun e-bug activities and kind of engage students in AMR and infection prevention. So you can see the photos there. But this year they had to be adapted with a focus on school newsletters and promoting use of the e-bug lesson plans. So 32 professionals participated to support their schools this year, or last year. Next slide, please. Another public and professional engagement initiative was the 5th Antibiotic Guardian Shared Learning and Awards event. So this was held in November of 2020. This championed organisations and individuals who have demonstrated achievements in tackling AMR at a local, regional or national level. So last year it was a fully virtual event with a new multi-country collaboration category. And despite COVID and everything going on, there was the largest number of entries received since the event started. Next slide, please. So if we cast a look back to exactly a year ago for last year's World Antimicrobial Awareness Week, it focused on 5 key areas. A toolkit was developed for healthcare professionals with guidance around promoting World Antimicrobial Awareness Week. This was downloaded over 700 times. The Twitter activity had really great engagement. So the most used hashtag was #WOW2020, which was tweeted almost 14,000 times. And there were over 52,000 tweets overall for the week, which is really amazing. And a range of digital resources for the week were developed for healthcare workers. So these included a daily Twitter poll with questions, and also a sticky note and a thank you note campaign, which were just a really great visual and innovative way to engage healthcare professionals in AMR. Next slide, please. So this is the last slide just to cover future actions. So the Target Toolkit will continue with the usual e-learning and training, and new actions are to develop further educational tools for the community pharmacy setting and to develop a suite of educational tools on skin infections to help integrate the updated NICE guidance. Additionally, the Target website has had a refreshed new look, so please have a look at that. eBug will continue to engage schools, and through renewing the resources from early years to Key Stage 4, and this will be rolled out this winter to all maintained schools. And they'll be seeking a new project to develop resources for children and parents in the hospital setting as well. But for the Antibiotic Guardian campaign, the School Ambassadors Scheme will continue, and it will encourage ambassadors to record a short video before engaging with the school. And the 6th Antibiotic Guardian Shared Learning and Awards event will be held in June next year. And an online module will be developed and piloted, which is based on the Healthcare Students AMR conference, so bringing all of those recordings together into an online experience. Finally, a workshop has already been run in a knowledge cafe style to share learning ahead of this year's World Antimicrobial Awareness Week. And hopefully you're all enjoying that campaign this week. And that's it. So thank you very much for listening. Hand back to Diane.
Thank you very much, Kath. Lots of virtual claps for you there. I'm going to now hand over to next slide, please. I've got that might be my setting. Hand over to Ella. No, sorry, go back to the previous slide. Ella Sonia, it's my fault. I've swapped my view slightly. Who's going to talk to us about the Keep Antibiotics Working campaign evaluation. Many of you will know that the Keep Antibiotics Working campaign started as a pilot in 2017 and then ran for 3 years. So we're very excited to share the findings from the evaluation and for Ella to present with us to us today.
Hello everyone, so I'm Ella Sonia. I work in the strategy and planning team as part of the behavioural programmes unit over at the Department of Health in the Office for Health Improvement and Disparities. We were formerly known as the PHE marketing team for anyone that has previously worked with us. So just moving on to the next slide. So as Diane mentioned, this was a campaign that was initially ran in 2017 as a pilot in the Northwest and then was rolled out as a national campaign. It was England's first multi-channel integrated social marketing and communications campaign targeting the general public as well as supporting healthcare professionals. And predominantly, primarily the campaign aimed to raise a public awareness and understanding of AMR and reduce demand for antibiotics. So the target audience was the general public, but we're particularly focusing on groups most likely to use antibiotics. So looking at women aged 20 to 45 who had primary responsibility for family health, and men and women aged over 50 who were more likely to take antibiotics, and then also healthcare professionals who obviously provide prescriptions for antibiotics. We ultimately, if I had to kind of summarize the campaign, I'd essentially say that it was all about trying to influence that transaction between a member of the public and a healthcare professional. So through kind of 2 strands of activity. One really was all about reducing patient expectation or demand for antibiotics when they're not needed. And that was communicated via messaging that explained that overuse of antibiotics increased the likelihood that they wouldn't work for an individual when really needed. And then the second strand of activity was really focused on increasing prescribers' confidence in resisting pressure to prescribe antibiotics when they're not needed. So part of that included priming patients not to expect antibiotics in an appointment. So we had lots of materials in different healthcare settings. And we also created things called self-care prescribing pads, which basically offered healthcare professionals something physical to give to patients to counter the loss aversion for a patient of leaving an appointment without an antibiotic. And then to reinforce both those strands of activity, all of our materials and creative reinforce the importance of taking a healthcare professional's advice. For example, if you're at your GP's, take your doctor's advice. Moving on to the next slide. So as Diane mentioned, we ran a pilot campaign in April 2017, and following on from that, we had 3 years worth of campaigns. So one in October 2017 that ran for 8 weeks, one in 2018, and then one in 2019, and that was the last time we ran a campaign. In terms of the evaluation, so as you would expect, we both ran evaluations after each campaign, so looking at kind of pre and post campaign tracking as well as various performance and media metrics, but then we also worked with an independent evaluation company to conduct an evaluation of the entire 3 years and look at all those findings collectively. And we also ran kind of qualitative analysis after each of the campaigns to kind of, help refine creative routes, etc. Worth saying that today, I mean, I'm going to be presenting kind of such a top line view of the evaluation, but we are currently working on a submission of the evaluation findings to a peer-reviewed journal, and with any luck, that will be published later this year for anyone that is particularly interested in the evaluation. So moving on to the next slide. So just a very quick note to say, I mean, we're presenting a bit of a snapshot of results over the 3 years. I think when we were setting targets for the campaign, we were looking at wanting to see significant increase from the campaign running the previous year, which is quite ambitious because we actually had a reduced budget year on year. So actually, overall, we are very, very positive to seeing the increases that you can see on this slide, even though that you can see that they're more marked in some areas and less marked in other areas. So just briefly to talk to these, we had targets around recognition, and those targets were met across the 3 years. Even though we had lower spend over the years, we did see recognition building on previous years. So you can see that in 2019 we'd seen increases of 15%, resulting in 7 in 10 adults remembering seeing the campaign, and that was a build. So this second element of exploring kind of public attitudes to AMR really links into personal risk. So we were aiming to improve the proportion of people saying that it is true that antibiotics will stop working for you if taken for the wrong things, because landing that is important to kind of increasing people's sense of personal risk, which we know was an important part of the campaign. And as you can see, year-on-year improvements. This, though, it's fair to say there were less marked improvements across this metric than there were for the other metrics. And were we to run a campaign again, I think we'd need to think about how do we land that sense of personal risk to someone. And then finally, we were looking at wanting to improve the proportion of the public agreeing with the fact that taking antibiotics when you don't antibiotic resistant infections. And again, we saw improvements there with the proportion with 48% of people agreeing that this is definitely true. And I think it was around 86% of the general public agreed with that, if you take into account the people that said that it's probably true. So moving on to the next slide. We also looked at hot state actions, so actions that people will take when they are, so whether they're in a GP setting or with a healthcare professional. So the actions that somebody will take when they are closer to the moment of wanting an antibiotic. And we asked people what they did as a result of seeing the campaign, and we saw that there was the campaign did contribute to improvements in hot state actions. So you can see at the top the dark blue bar is 2018, the light blue bar is 2019, and you can see that 10 percentage point increase in people saying that they were essentially less likely to ask for antibiotics. So they were more likely not to expect, insist, or ask for antibiotics. And specifically, there were an increase in participants reporting that they would go to a pharmacy or use 111 as a result of seeing the campaign. So that was a really positive result for us. Moving on to the next slide. So as I mentioned at the beginning, the campaign really had two elements to it. Yes, we were targeting the public to try and reduce the likelihood that they were going to ask for antibiotics and increase their likelihood to accept a healthcare professional's advice. But we also really wanted to support that patient-doctor interaction. We particularly focused on GP settings with this part of the campaign because we know the majority of antibiotics are prescribed through GP settings. So that's why this slide particularly focuses on that. And GPs were really positive about the campaign. So you can see here that there was increased confidence to say no to patient requests for antibiotics. And you can see that in 2017, so the far left, that figure was 70%, rising to 77% in 2018 and 79% in 2019. Moving on to the next slide. Of an evaluation which looks at kind of lots and lots of different metrics, but ultimately we think that the evaluation shows that the campaign did contribute to improvements at that kind of patient healthcare professional transaction level to improve better outcomes for the patient whilst protecting and ultimately we did that through making sure we reached the target audience, increased awareness of AMR, and supporting change among healthcare professionals. But one of the areas that if we were to kind of run a campaign again, we would think about looking at is how to increase that sense of personal risk of taking antibiotics inappropriately. And I think, it's obvious people have talked about this throughout today, but since we ran, there's been a huge shift in the health landscape, and that is in the form of the pandemic. And that would likely present both opportunities and challenges for any campaigning activity, again, that we would need to take into account. And I will stop there.
Thank you very much, Ella. I'm going to hand over now to Julie Robotham, virtual claps for you, who is going to take us through the research chapter.
Thank you very much. Yes, so I'm Julie. I'm the head of modelling and evaluation for AMR and also the AMR research lead. So it's my pleasure to talk to you about the research chapter. I couldn't possibly hope to describe all of the research that's been undertaken from 2020 through to 21 in the field of AMR that's come out of our group collectively. So what I'm going to try to do is pull out a few key research projects and also describe the research priorities which hangs together all of the research. Next slide, please. So those research priorities are fundamentally around data science. So really thinking about enhancing our data collection and linkage of that data to maximize its use. Transmission, which increases our understanding of both the burden and risk factors for infection and outcomes. Translational science, so thinking about the development pathway for new diagnostics, antibiotics and antimicrobials, as well as vaccines. And also interventions and evaluation, so enhancing the evidence base for both existing and novel control strategies. Next slide, please. So much of the research that's done in this field is through health protection research units. Next slide, please, which I'll just describe briefly. So the NIHR actually funded 14 HPRUs, as they're called, to run from April 2020 through to March 25 across a variety of topic areas. So these HPRUs are partnerships between universities and the UK HSA, and they're intended to form centres of excellence for these different topic areas with a real focus on collaboration and knowledge sharing. There were actually 2 HPRUs funded in the topic area of healthcare associated infections and AMR, and these are led by Imperial College London and Oxford University. Next slide, please. Both of these 2 HPRUs have 4 research themes within them, which I'll just go over the main research themes. So for Imperial College, they are priority pathogens, which conducts research looking into how and why microbes become resistant. Precision prescribing, which is really thinking about that work to optimize antimicrobial prescribing and thinking about tailored approaches. Practice design and engineering is research to help us improve practice and behaviour, really thinking about the physical environments and those patient pathways and how patients move through those physical environments to try and reduce the risk of AMR. And population and health policy, which uses both local and national data to try and evaluate the impact of policies and interventions and their consequences. Next slide, please. And then the HPRU with Oxford University, again, has 4 key research themes, and these are really complementary to the Imperial ones, and there's lots of collaborative work between them. So these are populations. So this is looking to exploit very large-scale linked electronic health record data to try and identify populations particularly at risk from AMR. The interventions theme works to combine very multidisciplinary approaches, so from behavioural science through to mathematical modelling to evaluate different interventions. Contexts aims to increase our understanding of the context within which AMR actually proliferates, so thinking from a very One Health perspective, so thinking about the drivers of AMR across those different settings. And sequencing aims to deliver public health whole genome sequencing services. Next slide, please. So both of these HPRUs actually build on research that was conducted in previous HPRUs, which ran for 5 years and ended in March 2020. And these really did establish the infrastructure and collaborations needed for that ongoing research. Those previous HPRUs conducted an impressive array of research projects. And in the annex of the research chapter, you'll find a list of HPRU research projects and, most importantly, the actual impact that they had in terms of patient and public health. Next slide, please. Just to pull out just a couple of examples of that translational impact from those HPRU projects. So at Oxford, analysis of over 4,000 Clostridium difficile whole genome sequences combined with electronic health record data demonstrated that declines that we saw in C. diff in Oxfordshire, similarly to those declines that we saw nationally, were driven by decreasing fluoroquinolone use. So this directly affected recommendations for fluoroquinolone stewardship through DHSC and PHE guidance, as well as in the US through CDC guidance. Next slide, please. And an example of translational impact from the Imperial College HPRU, a lot of work was done around the impact of culture and team dynamics on stewardship interventions. So this research showed that while the mechanisms that lead to AMR might be biological, the promotion or mitigation of AMR is profoundly social, and this really did enhance the application of social sciences to the field of AMR and fed through into a MOOC, which influenced practice in antimicrobial stewardship. Next slide, please. So just to give some brief examples of other research projects outside of those HPRUs, of which there are many and many more listed in the report itself. Next slide, please. So the NIH are awarded some capital funding to generate what was called an open access virtual centre for AMR innovation and research. So this involved a variety of research areas, one of which is the development of a unified infection data set, which was mentioned in an earlier chapter. But this is to provide near real-time linked patient level data. So this is data on patient infections, antimicrobial prescribing, resistance, as well as clinical outcomes. So this is really feeding into that kind of data science priority of linking our data to be able to make best use of it. And it also, other projects link through to that translational science. So the development of screening cascades for drug evaluation and innovative approaches for assessing antibiotic susceptibility to really help inform evidence-based prescribing. Next slide, please. There's also work on AMR in sexually transmitted infections. This is largely around the two main pathogens where the burden of resistance is greatest, which is Neisseria gonorrhea and Mycoplasma genitalium. So there's actually another HPRU, not an AMR HPRU, but an STI HPRU, within which there are some AMR related projects, one of which being assessing the feasibility and acceptability of using whole genome sequence data from Neisseria gonorrhea actually diagnosed in the sexual health clinics to help guide decision making and individualized patient interventions. And another is the development and rollout of a molecular test that detects ceftriaxone resistance in Neisseria gonorrhea. So ceftriaxone is currently the first line treatment, but it's not possible to detect resistance in nearly half of all UK gonorrhea cases at the moment. So development of that test really has the potential for large impact. And then thinking about our priority area of transmission, there's a collaborative work going on with ECDC, looking to perform whole genome sequencing on gonococcal isolates and combining that with other data sources, really to answer those kind of key questions around transmission, looking at resistance determinants, monitoring those AMR trends over time, and identifying transmission networks across Europe. Next slide, please. a whole stream of research around behavioural science, a lot of which you've heard about in previous chapters. So projects evaluating patient, public and prescriber perspectives on AMR and prescribing. So a few examples: an assessment of what the public understanding of AMR actually is, reviewing educational interventions which aim to reduce prescribing in children, and most recently research evaluating the impact of COVID-19 on antibiotic use, but also the patient consultation pathway and that healthcare seeking behaviour. So really feeding into that priority area of interventions and evaluation. Next slide, please. And another stream of research around modelling and health economics. So this develops novel methodologies to really help us answer research questions, ranging from quantifying the burden of AMR, so how much it costs, through to evaluation of interventions and cost effectiveness evaluation of interventions. So examples here are predicting the impact that AMR might have on surgical procedures, both now and in the future, quantifying effects of resistant infections on things like quality of life, morbidity and mortality, and feeding this all through to transmission modelling to help us evaluate interventions for particular organisms and in particular settings. Next slide, please. So there were many publications coming out collectively, which I can't possibly hope to go over, but hopefully I've given you a flavour. All of the publications are listed in the annex of the report, and I'm sure that the researchers would be very happy to hear from you if there's anything in particular you wanted to follow up on. Thank you very much.
Thank you so much, Julie. Next slide, virtual claps for you as well. Thank you so much. Okay, we're going to move on now to the stakeholder engagement chapter. And I highlighted and started the webinar by saying thank you to the engagement we have across multiple organizations, more than 22 of them. And it gives me great pleasure to invite Ella Casali to share. Ella has been instrumental, absolutely critical to the delivery of the ESPAUR report. She is the project manager who keeps everybody on task, on time. So really grateful, Ella, for your particular role in this. So over to you, Ella, to share about the stakeholder engagement chapter. And you got virtual claps before you even started.
Thanks so much, Sam, for the very kind welcome. Yeah, I'm Ella Casali. I'm one of the AMR programme officers at UKHSA. It's amazing to see 140 people still on this webinar at the end of it, so well done and thank you for staying on. I'm going to be talking about the final chapter in the ESPAUR report, the stakeholder engagement chapter, and this looks at the AMR and AMS activities of our amazing stakeholders and the work they've done between 2020 and 2021. Next slide, please, Carrie. So ESPAUR is a multi-professional and multi-organisational group. It's led by UKHSA. It's made up of a really wide range of stakeholders, including all the devolved administrations, lay representation and public and educational bodies, as well as healthcare providers and regulators. This year's stakeholder chapter includes summaries of AMR and AMS activities from 14 of our stakeholders. So I'm going to be running through a selection of the activities that they've undertaken, but full details are available in the final chapter of the report. And just to note that NHS England and Improvement was presented by Elizabeth in chapter 7, and there are details of other NHS activities in chapter 11 as well. Next slide, please. Thank you. So stakeholders have continued to contribute to tackling AMR and AMS, whilst also supporting the COVID-19 response. So, for example, the British Infection Association has developed new best practice standards for the delivery of NHS infection services, including specific recommendations for minimum AMS activity in acute NHS hospitals. And the Royal College of Pathologists. The BNF has continued to update their content in line with NICE guidance and other national recommendations on the use of antimicrobials. The antimicrobial key provide a resistant surveillance programme in Europe, offering more than 6,000 ICs.
Ella, reminder to switch off your camera in case it helps with the bandwidth.
Sorry. Good idea. BSAC also have ran a national susceptibility testing programme, as well as the OPAP programme, which is bringing care closer to home. The Faculty of Practice, which is now the College of General Dentistry, has co-published the 3rd edition of the in dentistry guidelines, and this reflects changes in the evidence base since the previous edition and covers
Just to check, is it only myself that's lost Ella?
Well, I've lost the two.
Okay,
Yeah.
no
I have
problem.
as well.
Of all the days for her Wi-Fi to go down, it was today. So that's fine. Next slide, please. So we've also had significant work done by Health Education England, particularly the AMS changes, where Health Education England funded University of Manchester to develop and developed a cohort of experts in behaviour change related to antimicrobial stewardship. And the tools that they developed as part of that has been used broader than within the NHS as well. And HEE also funded the Royal Pharmaceutical Society's antimicrobial stewardship training programme for pharmacists. The Specialist Pharmacist Service has been published its first national PGD template for immediate administration of a single dose of benzylpenicillin injection. And we know that we're continuing to work with them and the National Optimizing Prescribing Lead, Dr. Kieran Hand, as they consider further templates going forward, particularly around antimicrobials, and really trying to work in and encourage and the importance of building in surveillance as part of that programme. Public Health Wales continued their surveillance data for antimicrobial usage, resistance and HCI, healthcare-associated infections, and fed back to the NHS as well as Welsh Government, the Antimicrobial Resistance Lab for molecular confirmation of antimicrobial resistance as well. And then in Public Health Agency, the particular work they were able to undertake during this challenging time of COVID, for our devolved administration colleagues, there was significant redeployment to COVID-19 for all the core staff working on antimicrobial resistance within the agencies. They undertook public engagement to raise awareness of antimicrobial resistance through a social and mass media campaign. Next slide, please. And then the Scottish One Health is also represented as part of, Scottish colleagues are also represented as part of ESPAUR through we particularly highlighting the SONA report, which was published on Tuesday this week, just ahead of World Antimicrobial Awareness Week. And the Royal College of Nursing distributing a survey to understand nurses' engagement in antimicrobial stewardship. So we're looking forward to the publication of the findings from that survey. Royal Pharmaceutical Society delivered expert-led antimicrobial stewardship training program for pharmacists practicing in patient-facing role across all sectors. And I highlighted earlier that that was funded by Health Education England and was in collaboration with UK CPA PIN, as well as Public Health England as we were then, and now UKHSA. The Veterinary Medicines Directorate has published their annual UK Veterinary Antimicrobial Resistance and Cell Surveillance, and I think that happened last week. So again, significant work ongoing. We have the ESPAUR report from the human health side in England. Colleagues across the devolved administrations have their similar reports. I've highlighted the SONA report there from Scotland, and VMD have a UK-wide approach to their antimicrobial resistance and cells surveillance report. The National Institute for Health and Care Excellence, NICE, developed rapid guidelines for antimicrobial prescribing. I highlighted some of that during the stewardship chapter, but we also know that they did significant work around rapid guidelines to support management of COVID-19, which is obviously very important for tackling antimicrobial resistance and stewardship to ensure that the appropriate treatments were being recommended. Next slide, please. So that was all from the stakeholder chapter, and thank you to Ella for that chapter. I'm just going to hand over, well, I'm going to hand it back to myself. We're going to move on now to the Q&A session, and I just need a few minutes to have a look at the questions that have been collated. But if any colleagues have got any questions they wanted to verbally ask, please feel free to use the raise hand functionality on Teams. Thank you for the virtual claps. Okay. So hopefully colleagues have answered some of these questions already, but if I do read them out, then please feel free to verbally respond to that. So Jane, thank you for that comment. The APRI doesn't get a mention. So APRI is the Department of Health and Social Care's Advisory Committee for Antimicrobial Resistance and Healthcare-Associated Infections, and prescribing is in there as well. They are part, in many ways, a lot of those activities come in as part of DHSC, and DHSC's logo is there because they are advising DHSC. So that is the role of APRI. We obviously do go to APRI if we've got particular areas that we want advice on, and also we do present from ESPAUR to APRI when and where it is appropriate. So Jane is the lay member within APRI. So I think this question is for Elizabeth. Some good links. Can you please send the links of these, the list of these links via email? I'm assuming this includes press script and the various.
I don't think that was for me, actually. I don't know if the person who posted that.
Oh no, is it Julie? Okay, so this is a question from
when Julie was presenting.
Thank you, Elizabeth. So we will be sharing the slides for those who contribute to feedback, and then we'll be able to provide, you'll be able to click on those links through there. I'm just going to see if there are any other questions. Is there a collection of or plan to collect and feedback antimicrobial prescribing data across all healthcare settings, that is to include non-acute hospitals, prisons, and private hospitals? I think this was a question during your session, Elizabeth. Although,
I mean, yes, we're really aware there are sectors of healthcare access where we have no idea what the antibiotic prescribing looks like, and that's not great, and we do need to do something about it. I think the question is how we do that. So things like PGD supply is immensely difficult to capture because it's not routinely reported, for example. I don't know about prison, and I know mental health and community service providers, none of the sequence schemes are suitable to use in those settings because they're based on coding, and they don't code in the same way as acute trusts. We've been there and tried really hard, but we do need to do better.
Thank you. I'm going to bring in Sabine or Sarah as well into that question, because we have got some private hospital data. So Sarah or Sabine?
I'm not too sure about the private hospital data, but I know that we've included data for out-of-hours, walk-in centres, community service, urgent care, nursing homes, etc. That includes hospice and custody as well within our other category. But we don't have any private sector data yet.
Sabine, is that data still coming from EPAC though?
Yes.
Yeah, that's the trouble. If it's not an EPAC, it's very hard. That's our main data source.
Okay. Thank you very much, both of you. I think those are the questions. Just check one more. So there's I guess a question or comment or offer from Abid Hussein. Can our local Birmingham Antibiotic Advisory Group get involved in the synthesis of new community-based educational tools? Abid, are you still on the call? Are you talking about in general the community-based or the target resources? Don't know if Abid's still on the call. But I would say we take offers. There you are. Okay. Can you clarify, please? Yes, you're okay, target. So that's fine. Kath is on the call. I'm sure we would love to have offers of support. Thank you.
Definitely.
I've
made a note of that.
Thank you. I've got a hand. Thank you. So I'm just trying to see who. It is
Viv Weston.
Vivian Weston. Over to you. Please unmute yourself. You're unmuted already.
Yeah, it was me that was asking the questions about the further prescribing data. We have got engagement from our private hospital colleagues, and we have our nurse. There's quite a lot of PVV prescribing also going on, and I'm just slightly nervous that we're saying that we're happy community prescribing is dropping down, but we're not actually capturing the full picture. And that hence I was flagging this, and trying to engage with our local community healthcare trusts who have been excellent this week with World Antibiotic Awareness Week, etc. But they have no targets against them, so it's all done by persuasion, etc. And we know, when push comes to shove, some other things might go. So it's just really to flag. I think we should be trying to capture the full prescribing data if we can.
Thank you very much. We will.
Can I just add there? Obviously, the commissioners of those services, the community services, can negotiate to leverage that at a local level. Certainly, we've done that in the past with our community service provider when I was working in a commissioning organisation.
But it is understanding whether there's a major problem to then go at, is what I'm trying to say.
Yeah,
I agree, and I think there is something we need to do either at regional level or at national level, so that we capture that in a systematic way. And it's a point well made and taken. I've just had a comment in the chat from Jeff Featherstone, who is I may get his title wrong, the head of antimicrobial resistance program at NHS England and Improvement. Apologies, Jeff, if I've got your title wrong.
You got it right.
Sorry?
You got it right, I would say.
All right, good. So he says the issue of prescribing data from wider settings is an issue that Kieran Hand and I are looking at. So Kieran Hand is National Optimising Prescribing Lead for the AMR program at NHS England and Improvement. So there will be work done, and obviously we work closely, UKHSA works closely with colleagues in NHS England and Improvement, so I'm sure there'll be some collaborative working in there if they've started to think about it. Okay, I cannot see any further questions that have not been answered. Just check one more time, and just to say thank you to Ellie Harvey for collating these questions and supporting with that. Okay, so there's a comment here from Anna Hunt, who is a consultant in dental public health for OHID, was previously as part of Public Health England. So I think a few people on this call know that we don't have private dental prescribing data. That would be good, as would dental prescribing data at prescriber level or even contractor level, and dental prescribing in A&Es and by GPs. Too good an opportunity not to mention all of this. Thank you, Hannah. Noted. Yeah, there is so much more we can do around capturing data, and point well made around private dental prescribing. Okay, so I've got a comment here from Vanessa Enshaw, who says, I'm working in a mental and community trust and trying to come up with targets for ourselves for a QI project. And that's brilliant to hear, Vanessa. Please do reach out to us via espaur@phe.gov.uk if we can support with that at all. A few years ago, we ran a survey to consider what stewardship activities were ongoing within community health trusts. And as we would imagine, that were not, it was low in terms of engagement for stewardship. And so we do recognise that some of this needs to be done. But as Sabine said, we've started to build some of that data is available through in our other category. And perhaps what we haven't done is to break that down a little bit more. Okay, I think those are all the questions, which means that we are likely to finish the webinar early, which I'm sure will be great because you can have a few more minutes back of your time. Next slide, please. So many of you, I'm sure if you're on this call, you will know that it is World Antimicrobial Awareness Week. So just encouraging colleagues on the call, please put links into the chat. some actions that you can take. I'm sure many of you are taking it already. I can see several colleagues who are not part of the webinar or who are not part of presenters of the webinar, for example, have teleconference backgrounds on already in blue, or promoting stewardship messages. So that's great. When we finish the call, perhaps it will be an opportunity for more colleagues to switch their cameras on, particularly if you have a teleconference background, and we can take a group photo. But you can promote the ESPAUR report and share the findings. There are infographics available on that page. You are welcome to use those infographics as much as you want to. They are there to support you in sharing knowledge across your organizations. You can download and use the digital notes, which have a range of messages, and I can see through email signatures already, colleagues using those digital notes as part of their signature. They're snappy ways of providing information and very quick to share via social media, including WhatsApp or Telegram or other social media platforms. Talked about teleconference background already. Keep an eye out, actually, yes, a plea and an encouragement, if you're on Twitter or your organization's on Twitter, for them to visit the UK CPA PIN Twitter accounts. There are Twitter polls every day linked to the themes that we have for this year. There are 5 themes that we have for this year, and we encourage you to retweet those Twitter polls, to engage with those Twitter polls, to answer those Twitter polls. We've tried to base the questions on slightly controversial topics to get engagement, and just wanting to acknowledge the subgroup who have done a great so we from the national planning group, we set up a subgroup which included colleagues from the front line in 2020, and we've highlighted this already to develop the digital notes and what would be most practicable and supportive with on the front line. So a massive thank you to them again. And then finally, just to say, watch out for the AMR campaign, which will be in every copy of the New Scientist from the 25th of November, and includes it's a whole I think it's about a 16-page supplement on all topics on antimicrobial resistance, including colleagues from WHO, Dame Sally Davies, myself and Susan Hopkins, and colleagues at the Commonwealth Pharmacists Association, to name a few. It's a bumper edition. So that next slide, please. Just wanted to say thank you again, and I think we can just stop the slide for now before colleagues leave. And if colleagues want to just get on screen with their cameras, on, so we can take some group photos and show our support for World Antimicrobial Awareness Week, and going blue for AMR as recommended by WHO. Doesn't matter if you haven't got a blue background, it's totally fine. I'll just take some. So if other colleagues can also take, I'm not sure. Actually, I'm going to try and change the view. So I'm changing it to a large gallery view, which hopefully will mean more colleagues. Oh, that looks amazing.
We need more people to put their cameras on.
You've heard Elizabeth.
Not very impactful.
Okay, I've just taken one screenshot now. I'll take another one shortly. I'm going to ask colleagues to please feel free to take and tweet it. Hashtag. Hashtags are usual hashtags. If you obviously do not want to be on the screen, please do not turn your camera on. There is no pressure to do this. This is just our part of our way to show our support for World Antimicrobial Awareness Week. Okay, so just one final thank you. Smile.
Sorry, Diane, there's a hand up.
Oh, hand up. Who's the hand up from? Thank you, Alicia.
Sure.
Oh, it's me, Juliet. Thank you. It was just to say I've got my camera on, but it's not showing. And also, did you know that if you go on to more actions, you can get a together mode, which can put us all in it. You can just choose the number of people, more or less, on the call. It's quite fun.
We can see you now, Juliet, though, so that's good.
Oh, that's great. Hi. So shall I put us in together mode?
Yes, please feel free to.
I think you lose your background to that, unfortunately.
But it's so much fun.
It's not letting me do it, maybe because I'm not the organizer.
1 second, I can see a few colleagues. I'll take a few pictures and then we'll go back to the large gallery one. Thank you. I'll just say we'll just go back to the large gallery option. We could see you, by the way, Juliet.
Maybe
we
it's
can
me
see you. I
then.
think it's just yourself. Yeah, I can't see. Okay, so James. So once again, I'm trusting that my colleagues have taken screenshots that we need to take so I can move on. So once again, my final thank you to you all for joining us, particularly for staying right till the end. And we know that people have joined at different stages throughout the webinar, and for that we are grateful. We hope that you found this valuable. We will send an email with the link to provide direct feedback on the webinar, but we would also love your feedback on the ESPAUR report overall. So apologies, we're asking for two things. Feedback on the report, but also feedback on the webinar, just so we know if we should run this again next year. So we don't want to have webinars for the sake of webinars. We want to run them if they are valuable and useful for colleagues. So it leaves me then to say a massive thank you to all the chapter leads, the co-authors of the ESPAUR report, many of whom, majority of whom are my colleagues within UK Health Security Agency, but some are from other organisations. Elizabeth, for example, has led on the chapter she presented on, but we also have colleagues who dip in and share from across other parts of the health system, and particularly once again to our stakeholders who continue to engage with us and have been on the journey with us over the last 80 years, probably 9 years, since 2013, that we when ESPAUR was formed. So have a good evening, everyone. Thank you all very much, and we look forward to continue to engage with you.